education lead in my department. So I've been asked to cover a few things today. Before I put these slides up for us as well, I just want to see, because we don't usually deliver dermatology sessions to medical trainees, I just wanted to know whether any of you have attended any dermatology course or teaching session so far. No, never, neither as medical students. Yeah. As medical students, yes, you have covered dermatology. Okay. For those attending virtually, please raise the hand if you have had any type of dermatology teaching during your medical degree in or recently as a training doctor. Just to see whether you have had in the past any similar experience, because in dermatology we use a special terminology as well, and I will try to a little bit today. So not many of you, thank you very much. Let me then, well, it's good because today we are covering basic things. I will show you the topics we are about to cover today. Let me go to the presentation for you to see as well. So the topics I have, can you still see my screen? Boston team. Yes? Can you see the slide for the learning topics? Can someone of you unmute? Yes, if you can see that.
Yes, we can.
Ask me to cover dermatological malignancies, chronic diseases, and I have decided to cover psoriasis and eczema. That's the most common you will see in the world. And the last topic is for specialist therapists. So I decided to speak a little bit to talk about emollients and topical steroids, at least to boost your confidence when you see a rash, to know what things to prescribe until we come on the ward and see the patient. Before I start, and for those attending online, unmute and let me know, is there any specific thing you would like to learn from this topic today, to see if I have covered it, or at least to know and to cover it next time? Is there something in particular that you would like to take home today, something new that you want to learn, something that you don't feel confident when you're on the ward, and since you have me here, use my knowledge? Anything in particular that you would like to be covered today? No?
Perhaps not today if we do have time, but maybe in other sessions as well. I was wondering if we can get some teaching about scarring and non-scarring alopecias.
Alopecias. Well, it's not very common, and you don't see that on the ward. So I doubt this is to be covered in one of the 3 sessions that they have asked me to cover this year.
What about Berberas?
Sorry, what about?
Berbera.
Sorry?
Berbera crash.
What does he say?
I think he's talking about purpuric rash.
Purpuric rash.
Purpuric rashes, yes, and itching. Actually, that would be very useful, yes, because many patients do scratch and itch, so I can have that in mind for the next session. Yeah, and purpura and itch, both of them are very common conditions you see on the wards. So you were going to say
what
something?
are the most common referrals that we send to dermatology?
Yes, and this has been covered, but I make sure that it will be covered this year. It was covered last year, common conditions. And actually, I am one of the dermatologists who runs the ward referrals audit in my department. Okay. And I do have a list how many referrals we receive and what is the most common conditions you asked us to review. Yes, this will be covered for sure in the following year. All right, then, let's start. For malignancies, I have decided to cover only the 3 more common skin cancers, basal cell carcinoma, squamous cell carcinoma, and melanoma. But before we start with the topics, I will talk a little bit about terminology because we have a difficult new language there. And many of my colleagues in the consultant level ask me that, you know, all the junior doctors say, I have this rash. They need somehow to communicate about the findings they see on the skin. So these are the basics, and we will, with the presentation we will have today, you will hear about macules and patches a lot. So macule and patch is everything flat, so meaning that it is on the same level with the normal skin. So these are flat. The difference is the size. So patches is anything over 5 millimeters. Macule is anything smaller than that. So macules and patches, we are talking about flat lesions. The size is the difference. Plaque is something we see in plaque psoriasis. So in plaques, the plaques are slightly raised, only slightly raised if you compare it to the normal skin, and they have this plateau on the surface. These are examples of macular rash, a little bit blurry photographs, but these in reality are completely flat. Papules and nodules are the raised lesions. So again, the size will determine whether something should be called papule or nodule. Nodule is anything raised and over 5 millimeters in diameter. Papule is anything raised but smaller than that. Now, you don't have to write down everything because you will get that in a PDF anywhere from Anya. So to have it as a revision, but by all means, you can write anything you want. Okay. Okay. Now, these are examples of papular rash. If you would feel the skin on these cases, you would feel that something these are not completely flat, there's something raised there. Unfortunately, we have many more terms. So pustule is something we see in acne. These are raised lesions filled with pus, tiny ones. Blisters and bullous, you might have experience in your own life. Blisters when we have any burns. So we have, again, we are talking about raised lesions filled with liquid. The liquid could be blood or could be serum, like on the photographs. Bulla is the same with blister, but larger in diameter. On the wards, not very often, but sometimes, so you might see that in clinic, there are autoimmune blistering conditions, and bullous pemphigoid, the one that comes with large bullous, is a condition that you ask us to get involved in the management to immunosuppress the patients. The dermatology teaching, yes, just in time we were talking about the terminology. But you will get the slides after the tutorial from Anya. Lichenification is something we see when the skin is very, very itchy. These patients scratch and scratch and scratch, so the skin gets thicker and of course very dry. Lichenification is something we see in eczema, and anything that could be very itchy. Excoriation is something that has been scratched and traumatized, so the roof of the lesions is missing, and that's why we can see this more red erosion in the center because of the trauma. Again, something that we see in itching conditions like eczema. So let's start. I have already just for the student that just came in the room, several topics will be covered today. The first topic is malignancies, and we will discuss about BCCs, SCCs, and melanomas, which are the most common ones. Now, good photograph to see that each cancer rises from different cells. I should have a pointer, but it's not working, I think. So for the basal cell carcinoma, let me see if I can point somewhere over here with my pointer. No, it's not working. So I hope that this will make sense. Basal cell carcinomas comes from basal cells, which is on the border where this purple band starts, on the border to the on the deep end. Basal cell carcinomas. Melanomas start off from the same area because melanomas start from the melanocytes, which are again on the basal layer. Squamous cell carcinomas are more superficial, start from the keratinocytes. So it's a cancer of the keratinocytes. Does it make sense? It makes sense, but does it make difference? Probably not, because we will see in a minute how they look like. And they look similar, to be honest. Basal cell carcinomas. Now, dermatology will be very easy if we had only one presentation for anything, because we have 2,000 diseases and conditions, and the majority of them have different clinical presentations. And that's why it's something more, it makes it more challenging and difficult to identify what is what. So basal cell carcinomas are non-aggressive skin cancers, slow growing. We have several subtypes, which we will see in a minute. Starting with the nodular basal cell carcinoma, which is the most common of all skin cancers. Nodular, as the term suggests, is something raised, nodule. Skin colored or erythematous, not particularly scaly. Usually these patients will have the history that they've got it for several months, slowly growing, started bleeding, or some either might tell you that they have it for over a year. So we are talking about very slow growing cancers. Superficial BCC is a superficial subtype which looks like eczema. So what we see here is an erythematous plaque, if it is slightly raised. It might be scaly, might not, it might be eroded. The difference to help us whether this could be eczema or not is we don't expect skin cancers to be itchy. While eczema should be itchy, eczema usually comes with dry skin on the surround area or is bilateral, could be many areas of eczema, while the superficial disease is expected to be just one and not be itchy. A morphoic is a difficult clinical subtype. It looks like a scar. Our dermatoscopic tools help us to diagnose there. So I think it is too much for your level. BCC comes in a pigmented pattern as well. Sometimes the doctors think when they see this dark color, they think about, oh, could that be even a melanoma? So because it's something pigmented dark. But again, the history here would be that it is slow growing. And we also have a mixture of BCC and SCC. SCC, we will see that in a minute, is the most aggressive, more aggressive skin type. So we have a combination, we have this type of basosquamous carcinomas that has features of the benign, the not aggressive BCC, but features of squamous cell carcinoma, so it progresses more quickly. And we have this scale on the surface, which we usually don't expect in BCCs. Risk factors for a skin cancer, more or less, is the same for every skin cancer. Prolonged sun exposure, sunburns, sunnifications, fair skin that burns, increase in age because we expect the lifelong sun exposure to cause these problems. That's why the usual patient will be over 50, 60 for BCC or SCC. And immunosuppressants play a role for as a risk factor for someone to get a skin cancer. Management is easy. Of course, you ask the dermatologist to get involved. Excision is for every skin cancer. Easy to be done. We can see that, we cut the skin, we cut the cancer, and is the gold standard for every skin cancer to be removed with excision. Now, basal cell carcinomas, I repeat here, these are non-aggressive. They don't go through the 2-week wait pathway. Oops, for some reason, this is not full on the screen. Here the presentation, here's the slide would show that there are several surgical techniques, but again, it's outside of the level of your knowledge. And for the superficial types, we can give creams, we can give cryotherapy, freeze them with a very cold spray. So not always we will go with surgery. For the flat ones, we can try creams. Radiotherapy is for unresectable ones, for more aggressive or the ones that are too large to be removed. Any questions about the BCC?
How much is too large to be removed?
Oh, it can be as large as it can get. I mean, the surgeons, we have plastic surgeons and maxillofacial surgeons that do huge surgeries to remove different cancers of 10 centimeters. But with basal cell carcinomas, we usually don't have these large surgeries because these are slow-growing cancers anyway. For squamous cell and melanoma that are fast-growing, yes, we might end up with that large sizes. Any other questions for those attending remotely? No? Squamous cell carcinoma is a more aggressive skin cancer. This can metastasize and also gets bigger quite quickly. Risk factors the same: sun exposure, fair skin, immunosuppressants. The squamous cell carcinomas, if you remember the photograph I showed you, rises from the keratinocytes. That's why it's more scaly, dry, scaly surface. You can see that the actual red part of the lesion is quite raised, nodular. Very quickly they get this lumpy. So red lump with scale on the top, fast growing, yeah. High possibility to be an SCC. A few more photographs. In general, I'm about to show you several photographs here, so to get you get used of how things look like. More tricky squamous cell carcinomas to tell if it could be SCC or BCC. Again, you can ask the history, how long they've got it. It will need referral to dermatology anyway. And the way to find out is to have them removed anyway. Some larger squamous cell carcinomas could look ulcerated, could have a crust, fast growing cancers. Treatment, excision is the gold standard. It is a skin cancer. Non-surgical, we have the radiotherapy for the unresectable ones. The guidelines for management is complicated. We follow specific nice guidelines for every skin cancer. How about the margins to be removed and whether to offer adjuvant radiotherapy and for how many years to monitor them in dermatology. Now, just the photographs. Let's say that we've got this case. You've noticed it's a rosy, slightly raised black nodule, skin colored on the left zygomatic area. You ask the patient, oh, what's that? How long have you got it? And she said, oh, I don't know. It's been there for a year. Does it grow? Not sure if it is growing. What could that be?
To basal?
Most probably basal carcinoma. Yeah, most probably basal cell carcinoma. Here, the case might say that, I don't know what it is. Let's say it is on the scalp. Oh, you know, doctor, I also have this lump. How long you've got it? Just for a month. Yeah, it is more scaly and dry. So yes, the possibility to be SCC is higher there. Yeah, it's higher here. Before I go to the melanoma, now in practice, why do you need to know about squamous cell carcinoma and basal cell carcinoma? I suppose because you see elderly patients on the ward, and sometimes you do see lumps and bumps on the skin. And if they haven't done anything for that, you can check with the GP to escalate or inform the GP. We do receive some referrals, ward referrals about lumps and bumps. They are not that many because the medics usually focus on the conditions the patient has at the time of the admission. If we receive any, we don't go and see the patient, we just straightforward create a 2-week wait pathway, and we see them in our clinics as a 2-week wait, no matter if it is BCC or SCC, because we don't expect the medics to be able to recognize if it is BCC or SCC. But having a basic knowledge might be helpful, or it might be interesting for you to know. Any questions about SCCs? No? Melanoma. Everybody has heard about it? Yes, aggressive cancer. It can metastasize. Poor prognosis for the patients. Half of our cases might arise de novo, meaning that new melanomas comes on the normal skin. And the other half might arise in pre-existing moles, so mole that's been there for years and years, and at some point starts changing. We see melanomas more often in patients with many abnormal moles because the possibility one of them to change and progress to melanoma is higher. Several subtypes here as well. The ones that I have highlighted are the most common ones, and we will just see photographs and just very quickly get through the management. The superficial spread melanoma is the most common type of melanoma. It is multicolored, very dark areas. It is a mole, a change in mole, or a new lesion, very dark pigmented. Has anybody heard about the ABCD rule?
Asymmetrical border.
Yes.
Color.
Yes.
Diameter.
Yes. Yes. Whether there is a change in evolution or whether it is elevated, it is growing longer. The ABCD rule is a rule that definitely us and the GPs use a lot. We try to inform other doctors and on the wards that seeing something asymmetrical, irregular, dark color, many colors, it could be suspicious of melanoma. And I think I've got photographs. Yeah, for example, we can see on the right hand side there is a quite suspicious lesion, completely irregular border, many colors, asymmetrical. So this ABCD rule ticks a lot of boxes that this could be something risky for the patient and needs attention. While the photograph on the left is symmetrical, one color, even border, no concerns at all. The Kyriakou malignant melanoma is another type of melanoma, again ugly looking. We can see the darker color, multicolor, asymmetry. In melanomas, all the ABCD rules is the same. Anything asymmetrical and dark pigmented is suspicious. The Kyriakou malignant melanoma, that subtypes, is a type of melanoma that comes from the freckles that many of the elderly with fair skin have them. These start as innocent brown patches, but over the years, it might take up to decades. Up to the years, they might progress to something darker, indicating that might be progression to melanoma. There is a melanoma called acral because it is on the feet and the hands. Again, irregular pigmentation, dark color. Subungual, it is on the nail plate. Again, we have this darkening pigmented bands alongside the nail plate. But there are also melanotic melanomas, so pink. Not brown pigmented. So the ABCD rule here don't help. And it is the fear of every doctor, dermatologist, and GPs not to miss their melanotic melanoma when they first come up. They look like innocent cherry angiomas. But unfortunately, this grow very fast. The prognosis, the thicker the melanoma is on the histology slides, the worse the prognosis. It's something and information we get from the histology when we remove them. Excision is the treatment for melanoma. It is a skin cancer. The management is, oops, it has stopped working. The management is quite complicated. Again, we have specific guidelines for melanoma, when to request CT scans, etc. So if you are on the ward and you've noticed something on the skin, you could probably ask how long it's been there, whether there are any changes over the time and how quickly these changes have happened, whether there's bleeding or crusting. If the patient has already skin cancer, the possibility for another cancer is higher, some exposure. And that's the end of the part one. Any questions for those attending remote? Any questions at all? No? Happy to proceed with the skin rashes then. Eczema and psoriasis, quite a few photographs here to see. We will see the photograph in a minute. Psoriasis is an inflammatory condition, chronic. 2.5% of the population have psoriasis. So yes, many of the patients that will be admitted in the hospital will also have a chronic history of psoriasis. That doesn't mean that we need to come and see them. These are managed by the GPs with topical moisturizers and topical steroid creams. Of course, there are cases that need to escalate. That we do have cases that come and are admitted for the worsening of their psoriasis. And we will see a few photographs later today. What to know about psoriasis, apart from the fact that it is a very common skin condition, is that we can have some trigger factors, including medications, beta blockers. So if in elderly patients, if we have beta blockers as inhibitors, we know that this might trigger the psoriasis. So a well-controlled psoriasis for years and years might end up becoming worse and might need the dermatology input or to escalate treatment. But in reality, what we do, we first stop the medications. We ask the GPs to change them to a different one. Psoriasis is not contagious. Eczema is not contagious. All the chronic skin conditions, inflammatory skin conditions, are not contagious. Again, here is a difficulty, many subtypes of psoriasis. The most common one is the plaque psoriasis. Have any of you seen plaque psoriasis? Yeah, on the ward. For those that I didn't remote it, could you please raise your hand if you have any of you have ever seen plaque psoriasis, which is so common? No hands at all? Okay, we do have a couple of trainees here in Legon who has seen psoriasis. So plaque psoriasis, it comes with plaques. We now know this terminology. Slightly raised with plateau on the surface is a condition with a thick scale. We call them silvery scales, but white. Usually it is on the front of the knees and on the elbows. We will discuss the management in a minute. We have the generalized plaque. It can be generalized, so not only on the elbows and the knees, but it could be everywhere on the body. Again, we are talking about red plaques with the widest scale on the top, thick scale in psoriasis. Goutet psoriasis is something that we see usually in teenagers after a sore throat. They acutely get this papular, erythematous papular rash widespread all over the body, which thankfully it is self-resolving. Psoriasis can be on the scalp, again with red scaly plaques. Flexures, so genital area and the armpits. It looks like a tinea, so fungal infection. It does not improve with the usual antifungals. Thankfully, it is a rare condition that needs topical steroids. And it could be under the breast, on the umbilicus, it could be everywhere, but also involve the groins, the genital, and the armpits. Psoriasis can be found on the nails. Difficult cases, more severe cases of psoriasis is one of them is the pustular. Pustule, if you remember, is the one that has raised lesion that has pus in it, sterile pus, very painful because it is on the shoulders and the hands usually, but it could be also widespread. These patients cannot handle objects and it's very painful for them to walk. Erythrodermic, you might see that on the ward because erythrodermic patients get admitted in the hospital because in these cases, erythrodermic means that they have red inflamed skin that covers over 90% of the body surface. Skin is the largest organ of the body, so inflammation of the largest organs. These patients might have problems with the thermoregulation and electrolytes, so they might need support and fluids from the medics. Now, before I go, oops, the treatment, sorry. I think it is getting the other arrow. Yeah, I was pressing the wrong arrow. Let's go to the typical psoriasis. So, for example, you have a patient admitted for UTI, and they tell you that, yes, you've noticed that they have psoriasis, so they tell you that they have psoriasis, but they don't have their creams then. And you give them something while they will be 5 days in the hospital. What could we give to this patient? Just on the elbows and the knees. Yeah, Stavroula, Dermal. So moisturizers, we're talking about dry skin conditions. Dermal lotion, we will see that in a minute. It's the only liquid that we can prescribe as salt substitute. All the others, Aveeno, etc., they have to buy them over the counter. Any moisturizing cream would help here. Cetraven, Hydromol, E45, anything. But you need large quantities for them to apply them frequently during the day. Apart from the moisturizers, does anybody know what other type of creams we can give for psoriasis? No, it is a type of treatment.
But with the UV,
Eh?
with the radiation.
The radiation, yes, with the UVB, with the phototherapy, we might offer this. topical creams, the topical steroids is the best tool of dermatologists, and for the patients that have chronic skin conditions, topical steroids help eczema, help psoriasis, anything itchy, anything that it is not infection, skin infection, and usually and it is itchy, can be helped with topical steroids. And we will discuss a little bit about the topical steroids to get used to it, because I suppose prescribing topical moisturizers and substitutes would be fine and probably feel confident to do that while the patient will be in the hospital. But topical steroids, many of the doctors are still worried which one to give and whether I should give a topical steroid. So treatment-wise, emollients, substitute, topical steroids, and vitamin D analogs. Now, the most common product your patients will, and you might remember the name in the admission, they might tell you, you don't have the Dovanax from GP or the Dovabet. The Dovabet and the Enstiller are the most commonly prescribed medications, topical medications for psoriasis. It is a combination of topical steroid and vitamin D analog. Very effective, very useful. The majority of the patients with this mild psoriasis are managed by the GPs with these products, either Enstiller or Dovabet. It's the same product. For more widespread cases, widespread disease, the patients are referred to dermatology for light treatment, and here is when we give Psorilan as well. Or systemic treatment, immunosuppressants, methotrexate, cyclosporin, but nowadays also we have a biologic psoriasis. Any questions? No? No? Any questions for those that are in remotely? No? Happy if you have a patient on the ward with dry, scaly skin to prescribe moisturizers. The third part of this presentation is focused on the creams. Not a lot, just 3-4 slides, but eczema. Good question. Eczema and dermatitis. Is there a difference when we use these terms? Eczema or dermatitis. Anybody? Is there a difference? You can raise your hands if you don't want to unmute.
Isn't eczema atopic dermatitis?
So yes, we do use the same terms for the same condition. So atopic, you might hear it as atopic eczema or atopic dermatitis, and this is because eczema and dermatitis means the same. And dermatitis, it's the same. Several types of eczema. We will focus at contact eczema today, but also the atopic eczema, which is the most common type of eczema, and seborrheic eczema. That will explain now why. I have put a couple more in the presentation. So atopic eczema is the most common inflammatory condition. We see that in kids, in adults, it's chronic, relapsing. We have inflammation, and in particular, the barrier of the skin is disruptive. There is a genetic background. That's why it might run in the family. Psoriasis might run in the family. I forgot to tell you. So they might have other family members that have eczema. Impaired skin barrier, and in particular, with the eczema, then what we see here is that the whitish types like bricks are the keratinocytes, which are the cells on our epidermis. In eczema, they lose their connection. So this way, the patient with eczema lose a lot of water through their skin. That's why it gets so dry. And also because we lose that connection between the keratinocytes, irritants or bacterial infections, viral infections might more easily get into the skin. And that's why in eczema we have very often super infections, something we don't see in psoriasis. But eczema, they really struggle with antibiotics, one antibiotic after the antibiotic, because of this problem. So they have lost this skin barrier. Eczema, as I said, might run in the family, but also usually comes under the umbrella of atopic diathesis, as we call it. So the patients also have asthma and hay fever, or asthma and hay fever runs in the family. This triad goes very frequently together. How it looks? Different photographs. We don't see plaques here. In eczema, the redness is more patchy. Yes, it is scaly because it is another dry skin condition, but here the scale are more fine. We don't see the big silver scale we see in psoriasis. Yes, we can have papules, like on the distant part of the forearm. I think I can see couple more raised lesions. I can show you here, for example. So yes, it can be papular. We can see the excoriation. So because they scratch and scratch, they traumatize the skin. We might have cracks on the skin and whipping and pain. But again, you can see that the redness remains patchy. It might be around the mouth. This is a type of atopic eczema with affecting the lips and the surrounding area. Erosions, cracks. A mild case of dry skin, patchy, skin colored almost. And another scaly one. So mild, usually eczema can be quite widespread, of course, and severe, but if it is one or two eczematous patches, it's quite mild. You don't see the raised, scaly lesions we see in psoriasis. Again, another mild case of eczema. And the problem of eczema, because of the barrier, very often we have infections. Here is the impetigo. Have you heard about that? Impetigo. The alarm, the thing that will alarm you that something might be infected with Staphylococcus or Streptococcus is the golden crust. Wherever you see on the skin gold crust, this rings the bell for impetigo. It needs antibiotics. Eczema herpeticum. Herpeticum is because we have a viral infection here, so we have blisters all over the body. We see them on the pediatric ward. It's quite common in children. But again, eczema might progress to erythroderma as well. And they need admission in that case and referral to dermatology. Treatment. Thankfully, the moisturizers, salt substitutes, and the topical steroids are the same, like we discussed in psoriasis. And calcineurin inhibitors, I think it is too much for you to know. And bandages, we frequently prescribe dressings and bandages to stop them from scratching and traumatizing the skin and stop infections. But we also have systemic treatment, phototherapy, like in psoriasis, methotrexate, cyclosporine, in the use of immunosuppressants we use in psoriasis, but also biologics and JAK inhibitors nowadays. For the bandages, you can see how the skin can be protected from scratching it and excoriations, but also this way the greasy ointments that we ask them to apply stay longer on the skin and they protect it as a barrier, external barrier. several types of dressings, vests, leggings. We commonly give in these patients. Any questions for eczema, atopic eczema? No? A few things about contact dermatitis, which can be quite common in our professional because the irritant contact dermatitis is a type of contact eczema from irritants, from overwashing. During COVID, we had I had something. During the COVID, we had quite a few, many of us used to have very dry skin because we were washing the hands all the time. So, two types of contact dermatitis. The irritant is not allergic. It means that whoever uses that same product for that frequently for that many days, they will all end up with irritation of the skin of eczema on the hands. The allergic, in the allergic, as the name says, there is allergic background underneath. So two different people might use the same product on the skin, no reaction, one of them, but the other might react and get eczema. How they look the same, like eczema. Eczema looks the same no matter what the cause is underneath. So patches again, erythematous, dry, scaly patches. Here's a case of from overwashing the hands. Napkin dermatitis, we see that of course in infants from the urine. They do get this contact irritation. This is from saliva. If they lick the skin or they play with toys and they have saliva in it, they end up with erythema, popular erythema here around the mouth. Another type of hand eczema, again, dry, scaly skin, itchy, and can be painful, particularly if it starts cracking. And that's it. Only these few slides for contact. And we have two more types of eczema. I have decided to present the aesthetotic eczema because we see that on the wards and sometimes we do get referral. Aesthetotic eczema in reality is just very dry skin. It's something we see very often in elderly patients, and because the elderly are the ones that more frequently get admitted in the hospital, that's why you see this very dry skin and you get alarmed. But in reality, all they need is to moisturize the skin. We call it craquelé because it has the characteristic cracks on the skin. Itchy, patchy, scaly. Here's a milder condition, but you can see how dry it is. By prescribing a moisturizer, you will find improvement within 4 or 5 days of frequent moisturizers, and the redness will come down as well. That type of eczema. So itchy, scaly, macular patchy rash on the scalp, can be on the forehead, on the eyebrows is very characteristic, scaly eyebrows, nasolabial folds, might be on the cheeks, very, very common type of eczema. Yes, seborrheic dermatitis, very common, and chronic relapsing. Again, this will improve with moisturizers because it is scaly, it is eczema. There is association with malassezia, which is a fungus. So in that case, we give, of course, moisturizers, but we also can give antifungal shampoos or topical antifungals or topical steroids to calm down the redness. And usually these patients have long-standing history. They know that the GP have given them products at home. Some of them might remember that it is hydrocortisone or Dactapor is the most commonly prescribed antifungal cream, antifungal and steroid. And why I have decided to put this type of eczema here? Because sometimes we do get ward referrals, which are relevant with patients with redness on the face. The ward doctors get alarmed of what is happening. The seborrheic dermatitis is very common and has this characteristic presentation. We don't have to see them if it is long term. Just try moisturizers and then decide after a few days if indeed you want to refer. Stasis eczema, I think, is the last type of eczema I'm presenting again because it's very, very common. Stasis eczema or gravitation is the type of eczema related to venous insufficiency, swelling of the legs. What happens when we have swelling of the legs, which is usually bilateral? With the swelling of the legs, there is tension on the skin. It gets cracked, red, and itchy and dry. And very often there is dilemma from the ward doctors, could that be stasis eczema or could that be cellulitis? And I've got a couple of photographs. So stasis eczema, we expect it to be bilateral with patients with swelling legs. Again, chronic, dry skin, patchy areas on the legs. Another type of stasis eczema, bilateral. They have and some of the non-dermatologists, other medics have the knowledge that there is a term called inverted bottle because they have somehow on the ankles, the skin is more, it's not that swollen the legs, but on the calves we can see the red swelling. Now, very often on the wards ask us to identify if something could be stasis eczema or cellulitis. They usually say, you know, we have this patient for a week. We have tried this and this antibiotics. It's not improving. Please have a look. If it is bilateral, then the higher possibility is that we are talking about stasis eczema that at some point probably got infected. That's why the white cells and CRP got high. With the antibiotics, the infection improves, but the redness remains because the patient has swelling, like some stasis eczema. Cellulitis is acute. It can be painful. It's usually we expect it to be unilateral because we are talking about bacterial infection. What is the possibility to have the infection on the same time on both areas? And cellulitis improves with antibiotics. You usually do these markets and you check if there is improvement or not. Any questions at all?
Sometimes these people get blisters.
Yes.
What do we do? Just wait and watch? So
it is expected. Sometimes with severe cellulitis, you might even see blood inside these blisters and bullous. It's nothing to get that alarmed. It's something expected if you have this swelling and terrible infection. And we usually advise to prick with a sterile needle so that the fluid can leak. And the roof of the blister protects this way the skin for further infection. And sometimes when they have this chronically venous insufficiencies, they get blisters but without any cellulitis. Yes. Yes, and again, because there is not a good circulation on the skin, and having blisters, erosions, ulcerations is what we expect with this swelling legs. But also sometimes they might get in the lymphedema, you might see these solid lumps and nodules. Yeah. So again, it's something we expect in lymphedema. So we don't have to do anything. You don't have to do anything. Just treat the underlying cause. So it is the lymphedema. It is the chronic inflammation they've got in the skin. How to manage stasis eczema? Stasis gravitational is the same. So we have fluid on the legs. If we don't get rid of the fluid, there is no way we, the dermatologist, can help. So depending on the case, some GPs prescribe diuretics. or the bandages will do the job here. Compression bandages, but of course the patient needs to have a Doppler to assess the arteries and the ABPI before we give them compression stockings. For the skin, again, we are talking about eczema. Moisturizers will help. Topical steroids if it is itchy, otherwise just moisturizers. That was part 2. Any questions? No? For those attending remotely, any problems and any questions at all?
Thank you.